Hello and welcome to A Blind Date with Knowledge. Hey, we're back.
We are. Here we are.
As you've already just heard, the Dream Team are back together. It's Laura Brady and I'm Stephen Liggett. We both hot-footed it over Newcastle by train and by car to be here today at your...
How can you hot foot in a car or a train? Is hot foot not walking?
That's a good point.
Okay.
We've hot driven in hot.
Hot. We're all hot and bothered over here.
I'm a bit hot and bothered, but I'm pleased to be here.
Yeah.
At your old stomping ground, Laura.
Yeah.
The Centre for Life. How does it feel to be back?
It's good to be back. I love the Centre for Life. It's such a great centre of innovation, the centre of life, yeah. Well, I think a pioneering institute for research in our area.
It is a very inspiring place.
Yeah, for sure. And our inspiring guest that we're going to talk to today, I'm looking forward to our conversation with her. So it will be Dr. Lorraine Cowley, who's the Principle Genetics Counsellor here at the Northern Genetics Service within the Newcastle Hospitals Trust. And she's just received a funding award, the Clinical Academic Research Partnership Fellowship. Bit of a tongue twister. I think they call it the CARP Fellowship for short.
Fellowship, yeah.
So looking forward to hearing how she got this far and what she's planning on doing for her future research.
She's been described as a trailblazer for nurses, really inspiring. The research that she's done around genetics, and I'm hoping that she brings a lot of our themes together around involving the patient, how you generate data, you use the data. I'm genuinely excited to be speaking to her today.
Well, should we get straight to it?
Let's do it.
So we're here today with Lorraine Cowley. Hi, Lorraine.
Hi.
So would you like to tell us a bit about yourself and how you ended up in the role that you've got now?
Yeah, so I'm a nurse by background. I started my career as an oncology nurse way back in the 1980s/90s. It's a long time ago. And so I had done lots of different types of oncology care. I started my career in palliative care, then I moved into setting up a chemotherapy day unit. And anyway, I've done lots of sort of strands of oncology care. Then one of my patients said to me one day, like, "Oh, Lorraine, this cancer's genetic, you know." And I said, "Really?" I said, "I'm not aware of that. That's like not something I'm aware of." I thought, I better go and look into this. I ended up doing a day course. Went to see John Burns speak, actually, and he was speaking at the university. Went to that and was like really fascinated by, like, interested in it. So I went back to my patient and said, "Oh, you're right, I think I need to learn more about this." And then they discovered BRCA1, BRCA2, which are cancer susceptibility genes, particularly for breast and ovarian cancer, which is what my patients were referring to. And at that time, so before then, all genetic counsellors, as we're now called, were either like midwives or health visitors or social workers. And there'd never been like an opportunity for a nurse, a general nurse, to become a genetic counsellor, to do genetics. But because they discovered cancer-causing genes, they advertised a job for a genetic nurse specialist to look at cancer genetics. So that was something that I felt that was going to be another string to my oncology bow, but it's actually ended up being my whole career since then. So, but it's been a fascinating journey, and obviously sort of like being in at ground level, from them just sort of discovering cancer susceptibility genes to like having my whole career and seeing the developments over the course of those decades has been like really fascinating and rewarding. So genetic counselling became like a profession in its own right as my career progressed. So from being a genetic nurse specialist, I then trained to become jointly registered as a genetic counsellor. So I'm kind of dual trained now, and my sort of I'm now a clinical academic, and
congratulations, by the way.
Thank you. So I'm sure we'll be talking about the award that I've received later. But I started in oncology as an oncology nurse, being very interested in research and patient perspective research in particular, and that's because obviously in oncology there's a lot of clinical trials, and And I was nursing patients who were being part of clinical trials. And I just thought, wouldn't it be fantastic to get patient perspectives on being in a clinical trial? And like back in the early 90s, that wasn't something that was done. There was like quality of life studies, which are kind of very kind of quantitative type of things, or different ways of measuring quality of life, but there wasn't anything specifically qualitative research about patient perspectives, and that's what I wanted to do, and that's why I wanted to kind of develop this research career, but I never wanted to leave my clinical practice, so I wanted to have both. I wanted to have a foot firmly in both camps.
They go hand in hand, and you need to see both. So you've been there from like the very start with both the sort of oncology and the genetics. So I guess that's in line with the interest in research, as it's always sort of on the forefront. So how do you think that your perspective as a nurse impacted that curiosity?
Oh, well, so I think nurses, like, we see ourselves as, speaking for all nurses here, as very much as patient advocates, and lots of things are kind of like overlooked. I think that they're very simple things. They're very like kind of on the outside of like mundane things, but which are crucially important. So, for example, in a clinical trial, my first foray into research, when we were setting up a chemotherapy day unit and giving patients at the time like adjuvant chemotherapy for breast cancer, which was a very new thing then. And part of the treatment, to potentiate the treatment, was to give patients take-home dexamethasone steroids to take home. And I did my first piece of qualitative research, which I did for a master's. I was looking into the information needs of women who were attending this chemotherapy day unit. And I was interviewing a lady at home who, I had nursed and had kind of given her treatment. And she was talking about this dexamethasone. And she said, when I got that home, I just used to throw it on the fire. I said, oh my goodness. I said, what made you do that? She says, well, I don't want to be a bodybuilder and I don't want to be that. Okay. So it was a kind of like a very, very like a sort of a perception that was so important, crucial to her treatment, that we just completely missed. And we thought as nurses that we were given the best information, that we were kind of like really trying to see it from the patient's perspective. And really, we've all got these blind spots, and I think that's why patient perspective research is so important, so that we can shine lights into those corners, those blind spots, which does have an impact on patient care.
Absolutely. This is potentially quite a broad question, and I'm sure we'll come on to some specifics later, but it sounded like research was a large part of your department, even as a nurse. Which aspects are required for kind of research culture to be cultivated in clinical areas? Because a theme on some of our podcasts is how we, as researchers, I guess, engage with the wider clinical workforce.
So I think if there is like a medical research remit within your department, I think that's for me as a nurse, that's why I kind of piggybacked onto, if you like, kind of like I use that because people had that research culture.
Right, yeah.
So I think in the NHS, I think, if you've got that research culture, if you're in an area like that, in oncology it was always like that, in genetics it's like that.
Yes.
So obviously I can't speak for other areas, but so you have got that research culture embedded because people are trying to find answers to like medical problems and improving care and that kind of thing. So I think that you're kind of like one step in the door to actually saying, well, yes, but we need to look at this person holistic. It's not just about their treatment, it's about this. And I think that's what I kind of identified early on as I kind of piggyback onto that. They've got the research culture. Everybody wants to do the best for the patient, and so I just had to make the case for how my research would benefit the patient and benefit their care.
Fantastic.
Because I see sort of two sort of distinct, buckets of research there. That's sort of the forefront of oncology and genetics, where it's really unknown. But then, like you've mentioned, with the dexamethasone and that confession, there's a lot of sort of data there. I don't want to call it data, but there's a lot of things that we can observe that's already going on, that like health data and qualitative research that can also happen. So it's really exciting to sort of think about the fact that you've been in both of those areas, and then potentially sort of combining that perspective and making sure that the new research that we're doing does sort of from the outset include that consideration.
Absolutely, and that's kind of like what I've really wanted. That's the position I've voiced for like a lot of years, because it doesn't matter how clever or fantastic a scientific discovery is, if it's not acceptable to a patient, or it messes with their life in some other way that people haven't considered, then it's not going to be taken on board. We're not going to realise the benefits of that technology or that science, and patients aren't going to benefit from it. So it's very fundamental to get that view.
Potentially this is a nice segue in discussing your PhD. I have some questions from reading a little bit of your thesis over the last couple of weeks, but
I'm impressed that you did that.
because it almost encapsulates everything that we have discussed on the podcast, actually. So seeing that in action was really exciting. I suppose for those that haven't seen your work, are you able to summarise it now for us?
So I guess there was obviously there's like loads and loads of data in my PhD. It was such a privilege to do it. I guess the take home summary for me, which has like actually impacted my practice, it's about gaining an understanding. First of all, like we know this, that genetics isn't about an individual, that if you identify genetic susceptibility in an individual, that it's got implications for other family members. So it's about the differences in families, about who wants to know that information and who doesn't want to know. And as a genetic counsellor, we kind of want to do the best by any patient who comes to see us, but also we have that kind of like wider responsibility to family members, and we want to protect the right to know, but we also want to defend the right not to know. And it's becoming increasingly difficult to defend the right not to know in society. So within my thesis, I identified that one of the ways that patients ethically manage that discrepancy between individuals and families is they say that everybody's got a choice whether to know or not to know, which is obviously what the majority of people would subscribe to. But if patients had chosen not to have a genetic test, then they had somehow made the wrong choice. And so it became like a moral, it's a moral decision, it's a moral choice. And so whilst they were sort of saying that, yes, it's okay for people to make that choice, there was something about having that moral judgment that the phrase they used was that they are ostriches, they've put their head in the sand, and that wasn't a good place, in their view, for them to be. But my thesis was really about unpacking that and like thinking about what are the implications for society if everybody held that view, and really there are equally morally valid reasons to decline a genetic test, and the reasons that they said that people should have a test, because they said it was good for their family, good for research, good for society. So if you declined a test, it could still be good for your family, because if you were going to be burdened psychologically in such a way that you suffered long-term depression, then you're not going to be able to look after your family in the way that you want to look after your family. So there's ways of reframing that moral judgment so that it's got equal value. And I used that when I came back to my clinical practice, because it gave me confidence to identify the moral agenda in clinic. And quite often people come to clinic and you can tell that they might even say to you, well, I don't really want the test, but I'm here because for my family, or my wife's put me under pressure to come here, or something like that. That they give you some indication that they're not really there solely for themselves.
Their own choice.
Yeah, and I've kind of been able to unpack that for them, and I've used those kind of like words, saying like you can still morally be doing the right thing by declining the test. You can defer. You can come back. You don't have to make this decision today. And I've had like visible reactions from patients where they've relaxed, sighed, relief, and it's been so powerful. And people have still made the decision to go ahead and have the test. Quite often people who come through the door, that's what they are going to do. They might defer or they might come back. But I just feel like I've given them a better service because they have made that decision on their own terms, not feeling that they've been coerced by other family members to do it. So once they know they've got that like opt-out clause, and they still can be a good person, a good parent, a good sibling, a good, family member, then I thought that was very powerful.
Yeah, you described the emotions really well, especially when children are involved. You're getting the test to be the best parent, or
absolutely.
So there's a lot of emotions, and it isn't as you've just described so well there. It isn't all about the data or the diagnosis. There was a quote in it from a participant who describing having an information about the diagnosis as a way of changing kind of habits or lifestyle changes to prevent the possibility happening. I suppose the one question I had from reading it is that a way of kind of using genetics as a holistic way of changing lifestyles and behaviours?
So that's interesting because I think, so I haven't looked at the literature recently about that, but there was actually no evidence that the last time, which to be fair is quite a long time ago that I looked at it, but there was no evidence that having a genetic diagnosis had an influence, like behaviour, like intention to change, yes, but actual change, it didn't. So I kind of, so for example, if somebody was wanting an opt-out of like not wanting to test, you could, or is like kind of like exploring all of their options. All of us can change our lifestyle and influence our risk of developing cancer. So you can do that without knowing your genetic makeup, can't you? So if that's kind of put forward as a reason to be tested, we don't need to have that as a reason to be tested. We should all be doing that anyway.
Interesting.
So shall we move on to your upcoming research? Would you like to tell us a bit about how sort of your career so far has helped you sort of pull together that proposal?
So first of all, I just want to say that this isn't that this is my sort of success story, but there's been like a lot of unsuccessful attempts at getting funding along the way. So I just want to put that out there because that is a reality, and it's like kind of, it's great sitting from this position when you've got funding, but I absolutely know what it's like to be sitting in the position where you've been knocked back, haven't got it or anything. So
it's a long journey.
It is a long journey, and I just don't want to like kind of be that person who's just like putting it out as if it's like all rosy.
No, we'll do that for you. We're here to celebrate it, but it's definitely important to acknowledge how the efforts that it takes to get there.
Yeah, and just for people who like, if they haven't been successful yet, it is worth persevering.
Yeah.
And so this project is genetic testing, whole exome sequencing, a specific type of genetic testing in patients in 15 countries in Latin America who have hitherto undiagnosed neuromuscular diseases. And it's on the back of a project called Latin SEQ. And Latin SEQ is my colleagues in the muscle team in Newcastle. They got funding from pharma companies to offer 1,000 whole exome sequences to patients in these countries where they wouldn't normally have access to that kind of testing. And 40% of those diagnoses of people with neuromuscular conditions are undiagnosed or don't have a genetic molecular diagnosis in those countries. So it was a way of them kind of like taking this technology to those countries that wouldn't normally have access to them. And they invited me to be the genetic counsellor on the project, but there was no funding attached to that. So my project has been built around that and to evaluate the patient perspective, most importantly, the family members' perspective and the clinicians' perspectives of offering that service, of delivering that service. So some of the issues that I want to explore are, so for example, in the UK, the reasons why we would find a genetic test result beneficial potentially is that we could get access to possible gene therapy, we could get access to better supportive care, our family members, or we might have access to prenatal options like for future pregnancies. And in the Latin American situation, that could be quite different, so that there might not be the infrastructure to offer better supportive care or gene therapy, and there might be cultural tensions and barriers around prenatal testing. So that's going to be like rich areas to explore. But also in the majority of those countries, there isn't a genetic counselling service. So these will be neuromuscular clinicians who will be doing the consenting for genetic testing. And that will be interesting because in the UK, the genetic testing is being mainstreamed. So, whereas genetic counsellors are a specialist service, and as genomic medicine is becoming more widespread, there isn't access to all of those different services for genetic counselling. So, one of the useful outputs for doing this is to maybe learn lessons from how people have delivered that service in countries where genetic counsellors aren't widely available.
Yeah.
What can we learn in the UK to bring it back? But also to feed back to the different individual centres across those countries. I want it to be like useful information for them. So I really want it to be like collaborative partnership and working with those people.
That's amazing to hear, and it links back to what you were saying before, that every party or stakeholder, should be receiving a benefit from that. So that's really exciting. So how long do you think you'll be in South America at some point?
Yes, so I've got funding to have 3 field trips there. So the project lasts for 3 years. So my first field trip I'm planning for May this year.
Exciting.
And that'll be I want to do some PPIE, some public patient involvement and engagement work. So that's what I'll be doing. I'm in the process of trying to set up those meetings.
If there's any space in your suitcase, give me a
Stephen, you're not the first to ask.
That's true, I'm not now, but
Well, I have a question.
Last,
A big question. How's your Spanish?
No. Muy bien.
Well, that's good.
No, it's I've been learning on Duolingo for the past 2 years, so it's not. I'm not confident to speak it, but I do understand it. But I'm going to be having some. We're going to start having Teams meetings later this month, and they'll be in Spanish and English. So I'm hoping that my Spanish will improve once I hear it spoken a lot.
It's just to go back to what you said at the start of that conversation about your new research, about the fact that you've had to apply for funding, and you get knocked back and you keep going. I think it was the executive chief nurse described you as as very tenacious, very driven. And she praised your leadership qualities. So one of the other strands of the podcast is kind of we ask. I mean, it's a very difficult question to answer, I guess. But have you got any traits that you think have served you well in the development of your research, or as how you're perceived as like an overall leader?
Well, obviously, I don't really know how I'm perceived, but I know I have I just have I guess everybody has their core values, don't they? And I just try to keep it real, keep grounded, treat everybody with respect, and be kind to people, help people. Always kind of be aware of all of the people who've helped me, and just have that ethos of giving back and making it as nice an environment as you can to work, because we spend most of our lives at work, don't we? So we want it to be a nice environment, and it's just good for all of our health and good for patient care, because if we're happy, we're working as a team better, and then we're delivering care better.
Yeah, that's amazing. It's that theme of reciprocity as well, sort of being able to ask for help opens that door to being able to then give help in the future and have that balance.
Definitely.
So is there anything else that you'd like to say before we close this conversation?
I don't know who's going to be listening to this, but if anybody wants
hundreds and hundreds of
but if anybody's interested in research and kind of like wants to, have a clinical academic career, this is like the best time to do it, because there's things that exist now that never existed when I wanted to do it. But if I was starting out now, I would be jumping at those opportunities because they're out there, like all of the opportunities within our trust, the NMAPs, nurses, midwives, and allied health professionals, the 4Ps program, but there are so many opportunities out there that people could take advantage of, and it's a very rewarding career.
So now that the role of a genetic counsellor is officially recognised, then what does that mean for the sort of integration of research with genetics?
Well, there's one of the routes to become a genetic counsellor is via the scientific training program, and where genomic counsellors are trained for 3 years, and they get an MSc at the end of it in genomic counselling. And one of the things that they have to do is a research thesis. So that has been fantastic in our department, because every trainee who comes through has been doing a project based around our patient care, so an area that we can improve on, an area that we have a question about, and they develop their projects around that. So it's very much embedded in our practice, and it's really developed the research culture in our area.
That's so great to hear that it's integrated.
Definitely, yeah.
I mean, I'm super proud to be from the North East and to be working in the North East, and it's great to hear all of the research that you're doing and doing in the future has been conceived here. It's been delivered in the North East, and you're doing great work to put the North East on the map, and you're doing some fantastic research. So the last question for me is there anything you'd still hope to achieve in your career?
I just want to deliver good research, and I want to do the best by this project that I've got. I want to really, without sounding too grand, but I wanted to pave the way for other nurses to be able to access this funding. I want to deliver the project in the best way possible for every partner in the project, but also I'm mindful that this is like kind of a groundbreaking step for the MRC, so I want them to carry on supporting nurses.
I'm sure you will, and keep setting those high standards for people to follow. It'll be great. We'll follow it closely, and I hope 100%. It goes well. Best of luck for everything.
Oh, thank you. Thanks so much.
And just said it's been a fantastic conversation.
I've really enjoyed it. Thank you, and thank you for asking me. It's been a real pleasure. Thank you.